Oh, hey, Chris.
Hey Chuck, how are you?
It's been a pretty good day. How you been?
Doing well. I'm excited about the new segment we've got planned. I love the fact that you have no idea what's coming your way.
I'm a little frightened. You scare me a little bit with I'm giving up control here. I don't know if I'm comfortable with that.
Yeah, I know, and this is why it's even better. Before we jump in, do you have any interesting listener feedback to share with us?
I do. So, I was at a fellowship reunion a few weeks back, and it was fantastic. And I was asked to speak on social media. So I shared some thoughts on Twitter and Instagram, and I shared some thoughts on the podcast. And it was interesting that some people had heard of the podcast, some people hadn't. A few of the people who had not heard of the podcast since have logged on and listened in. So this is from one of my former co-fellows. This is from Mike Dodonna, who was a year behind me, and he gave me permission to share his review. Chuck, it was so great to see you in Jackson Hole. I've just completed a deep dive binge listen to the podcast, and here's the feedback I promised. The podcast is, in all caps, absolutely outstanding. You and Chris are fantastic. I love this. The two of you are unbelievably engaging, entertaining, authentic, honest, funny, and of course, extremely knowledgeable. I love the breadth of topics as well as the depth and clarity you provide on everything from patient presentation and indications to surgical techniques with great detail and specifics, down to the number of sutures you use to close the carpal tunnel. And love the Kefauver box, which is what we call the retractor placement for the carpal tunnel, as well as discussion of complications, therapy, and everything in between. I've gotten my whole team to listen with one caveat. They can't move to St. Louis to join you guys. You're that good. Congrats to you and Chris. Thank you very much. And so, wow, Mike, that is really, really nice. We appreciate the kind words.
That's awesome. And you have now managed to mention that you did the Stern Fellowship at least 4 times in the last 4 episodes. So that is fantastic. Great fellowship. We're very thankful to Dr. Stern for training an incredible number of amazing hand surgeons.
Well,
Chuck included.
It's interesting. I'm trying to feel young by harking, back to those days. But it is amazing, when you think about your legacy. What does that look like? Is it the patients you treated? Is it the articles you wrote? Or is it the people you touched and educated? And I think the older I get, the more I realize how impactful that process is. Looking in that room with all of those former fellows, it was really meaningful.
Well, that's great. And, perhaps we should get Dr. Stern on at some point just to talk about that topic.
I would love that. And he would love that. I feel confident. You would know better than I, given your close podcasting relationship with him.
Yeah, he's part of the side gig. The side gig is actually resuming again in October. So Firsthand is coming back in October. We hope it's been long enough that you've missed us, but we're excited about that.
You've been renewed. Congratulations.
It was a competitive process. So here is our new segment. It's called Wheel of Hand Surgery. So speaking of engaging our listener community, the topics for this Wheel of Hand Surgery have been submitted by the current medical student on my rotation, Ruba Sokrab, who is going to be doing her away rotation at the University of Michigan shortly. So anybody up in Ann Arbor, look out for her. She's fantastic. Noelle Palumbo, current PGY3 resident in orthopedics here at WashU, and Lauren Wessel, current outgoing hand fellow here at WashU. So Chuck, 6 topics on the Wheel of Hand Surgery. Very high tech, 6 Post-its in a circle. Okay. So what I'm going to do is I'm going to spin a pen, and whatever topic we fall on, we're going to talk about for 15 minutes.
Perfect. I love that. While you're about to do that, I do want to say that I looked at our reviews online, and we don't, this is totally side gap. I'm not demeaning your Wheel of Hand Surgery, but I do want to say that I was reviewing the questionnaire we asked listeners to fill out. If you haven't done that, please do it. And they were very clear that they like the Nerve Talk. They want more sports. They want more technical. So we're going to do that. But I also want to emphasize that the mugs are coveted, and there are people that really want our mugs. So we're going to send a mug to people who send in questions that we answer on air. And I'm going to send Mike a mug for his generous review. So sorry, Chris, I had to get that out. I'm old. I forget things. I have to say it when it comes to mind.
And I did want to say, Shobit, you're not getting a mug until your paper's published. So there's that. Current fellow class is dying to get mugs, and Jeff Steppen, you're finally getting your mug, and we can't wait to have you back. So, and Micah Sinclair, we should get you a mug too. Anyway, so on the wheel of hand surgery,
Chris is being generous today.
Micah listens every week, and we co-chair the government affairs committee for the Hand Society. She does great work, so I think she's earned one. She has to work with me on a committee, so.
Amen. Thank you, Micah.
The inclusion criteria are expanding. So let's see here. Topics are favorite instruments / preference cards, preparing for new or unfamiliar cases, didn't see that coming, and I'll elaborate more as that comes up, SLAC Wrist, never have I ever, and networking. So I'm going to spin this, and I just want to know before I spin it, which topic do you least want?
I think they're all fine. I'm willing to tackle any of them.
All right, here we go. Spinning. SLAC Wrist. Of course, the only clinical topic, but we can get into some technical stuff. So on this wheel of hand surgery, the SLAC Wrist is being removed and shall be replaced by a new topic. It will be sports, I promise, for next time.
Perfect. Well, this is great because those of you who can't really envision what this beautiful wheel looks like, just join us on YouTube. You can actually see it on our Zoom podcast.
We've been slacking on the social, meaning I have been slacking on the social. I will post a picture of this amazing wheel of Post-its. But so this is what happens when you don't get your sports surgery on and you end up with a SLAC wrist. So Chuck, so let's talk about SLAC wrist. So how often does this actually come up, and what's the classic story for a presentation of a patient with a SLAC wrist?
I guess I would say it's a bimodal age distribution, and I use that term just because I wanted to work that into a sentence. There's the youngish patient.
There's the Chris injury and the Chuck injury.
Fair enough. Although I might spread us apart a little further.
I would probably, yeah, okay.
So maybe there's someone my age who fell a year and a half ago, had some wrist pain, it went away, and now that wrist pain has come back with a vengeance. And then there's the patient who's 65 or 70 who comes in with wrist pain. And to me, it's super interesting because you don't need an x-ray on that 65-year-old. You can look at that wrist and know what the diagnosis is. But I think for me, there really are two populations.
So I think I know what you're talking about in terms of what that wrist looks like. And it's always that wrist that's just like a little swollen in the right spot. And it hurts, obviously. I mean, you're not just looking at it, you can tell, but you know where it's going to hurt. How do you ask them if they had any trauma in the past? Do you buy the story? Do you believe them? Because most people don't know.
Yeah. So again, just to make sure we are crystal clear, we don't want to be obtuse, but dorsal radial swelling at the radioscaphoid joint and point tenderness there is the tip off. But again, you can see it just by looking at the wrist. I always ask. I don't know if it matters. I guess it's just part of the discussion, but I always ask. Do you?
I do, just to see what happens. I don't believe him. But yeah. I actually, this patient came in to see me recently, one of my recent clinics. And, I immediately knew what was going on and was very curious to see what the x-ray was going to look like. And lo and behold, it was already a SLAC wrist. So for the listeners who are earlier on in training, let's talk through the progression of a SLAC wrist. So you have an injury to the SL ligament, which leads to some element of instability. And eventually, because that link between the scaphoid and lunate is no longer intact, the scaphoid will flex. So what happens there, Chuck, in terms of, the contact pressures, yada, yada, yada?
Yeah, I think we could go deep. We could go deep dive into the biomechanics of how the carpus works, but I think you said it really well. Without that scapholunate ligament, the scaphoid is going to flex. When the scaphoid flexes, the pressure between initially the styloid of the distal radius and the scaphoid waist, and subsequently the more proximal distal radius and the more proximal scaphoid, the contact forces increase. And because that's not the regular load bearing pattern, and you get arthritis there.
So maybe just for completeness sake, when we replace this on the wheel, we'll put scapholunate ligament treatment and go a little more into that. But let's say that ship has sailed, it's an irreparable ligament, and you've already developed arthritic changes. What do you tell that patient? I tend to kind of give them, hey, this process has already started. We can't cure it. We can treat it, but we can't cure it. I typically will start them with a brace and a steroid shot, and a steroid shot if their pain is real bad at that point. Do you offer anything different than that right away?
No, I think that's exactly right, because you can make a patient dramatically better. I will say I'm not one to give steroid injection after steroid injection after steroid injection, because I do believe there are negative consequences when you are potentially salvaging some of the articulations of the wrist. And so I think a single injection with the offer of a splint works great, and give the patient a chance to see if they like it, if they can work with the splint and it solves their problem either temporarily or more long term. And then if they fail that, then we have options. We have good surgical options.
So, but what do if you're putting in steroid and say you're doing some surgery down the line that preserves some elements of wrist motion, what are you trying to save really? Because I mean, if you're assuming your steroids in the right place, you're not really affecting the mid-carpal joint. Are you thinking it's the impact on the radius cartilage itself?
Yeah, I think I mean, again, I don't know the science like some listeners probably do and some scientists probably do, but I think it's pretty clear that repetitive steroid injections have a negative impact on the cartilage. And so the radiolunate joint, if you're going to consider, a scaphoid excision and four bone fusion, or we know that the scapholunate ligament's intact, and so the steroid will migrate to the midcarpal joint as well.
So what's your current thought process on procedures other than a four corner or a PRC? Do you see any role for like a radial styloidectomy at all? Like how does that, or even arthroscopy, some might argue?
Yeah, I mean, I guess it depends a little bit on the severity of the arthrosis. I mean, if you catch something really early, a scope in my mind has a role for confirming the diagnosis, maybe. And I don't really believe in the whole cleanup procedure in this situation, although some might advocate for that as buying time. I don't do a lot of radial styloidectomies. Those can be done arthroscopically or open. I think they're pretty straightforward. There was a ton of research done in years past, especially by Dr. Gelman, quantifying what type of osteotomy made sense, what angle the osteotomy was to protect the ligaments. I just don't do many in 2021. Do you?
I don't, and thank you for triggering me just just then. Oh, the origin of the radioscapic capitate ligament. So, okay. Well, I guess in the short time that we have left in terms of the technical aspects, how do you decide between whether you're going to offer a PRC or a four corner fusion?
I think I do it. Well, first of all, the literature has become more clear, right? The PRC is better. It's less revised, it's less expensive. Patients are equally happy. And most of us like the PRC. I probably do more four bone fusions than I do PRCs. Having said that, of course, everyone's like, what the heck is he talking about? I think they're both good options. I really do.
So, well, an interesting thing, I saw a patient as a second opinion very recently who had a very straightforward issue and was recommended to have a PRC by somebody else and came in and was like, that just sounds ridiculous. So how do you explain this procedure to the patient of, we're going to treat your arthritis by removing an entire row of bones? I mean, clearly we have to have that conversation for thumb CMC surgery, but it just seems weird.
It's a hard sell. So my conversation goes like this. If I'm selling a PRC. So you have this significant arthritis, we have to get rid of this arthritic bone. And thankfully, we can use other bones to support your wrist. There's an operation that's been around for 100 years. Anything that's been around this long has got to work. And and I draw a little picture, a terrible picture. We laugh at my art, and then I explain what we're going to do, and I explain that I trust this procedure, and usually that convinces them. Are you sold?
I, I love it. I'm learning here. This is great. So then how do you sell the four corner fusion?
I do tend to use this stereotype, if that's the right word, for four bone fusions, in that I think it does maintain carpal height. I do believe it probably has some advantages from a strength perspective, and it maintains more normal anatomy. And so for the patients that either A, are freaked out by the PRC, or B, or a little younger and higher demand, I think the 4-bone fusion makes sense. And I do still perform a 4-bone fusion. You know, the concept of just fusing the capitalunate joint has become a little more in vogue lately, but I like the 4-bone fusion and I still do it.
So are you also taking down, the side to side articulations, or are you just doing like a 2 bicolumnar kind of fusion?
Yeah, I like, that's a great question. I like that. I tend to really address the 2 midcarpal joints. So the capitalunate joint, I decorticate and I fuse that one. And I also fuse the joint between the hamate and the tracheatrium. In a perfect world, I have 2 screws, one going from the lunate into the capitate, and a second going from the tracheatrium into the hamate into the capitate. And I really like that. And I've been very pleased with the results that I get from that.
Yeah, so we were on our travel club meeting via Zoom recently of the younger generation of hand surgeons. And we were discussing this very topic. And, I felt like an outlier because there are some of my colleagues are using plates more and feeling more confident in moving them earlier on with the plates. And, saying that, there are some reports of construct failure with the type of construct that you just described and that I use regularly with early motion. So what, if you could do a 4-corner or 4-bone bicolumnar kind of fusion and move them early, you think that would make a difference in terms of the evolving literature between PRC and 4-bone fusion?
Fundamentally, I don't believe that it's going to increase motion dramatically in the long term. It might make life a little easier in the short term. I guess the question is, would you trust your plate and screws in the lousy lunate bone? That's ultimately, to me, the riskiest issue. The lunate bone is not healthy. It's small, and we're trying to make sure it fuses because that is the key to the whole operation. So I respect that people are doing this. I don't feel a strong need to investigate it, I guess, is my response.
And then the other thing I think that's challenging about these sometimes, if is getting the lunate correction and getting the lunate correction, but then also being able to get your screw in the right position in the lunate. Because essentially you've taken down the midcarpal joint, your capital lunate joint's taken down. You're having to flex down essentially the wrist to get that lunate in neutral posture, but then also get your screw kind of in the center of the lunate, volar to dorsal. Do you have any tricks for that? Because, whenever, I try to do that, it's a little more challenging just because you end up flexing your wrist, but then the mid-carpal joint opens up and I try to keep it closed, but it's challenging sometimes.
Totally agree. And it can be really challenging. I would say a couple of things just to make sure, following up on the biomechanics, without that scaphoid to tether the lunate tends to go into DC. So it dorsiflexes. And so our goal with the surgery to create the greatest arc of motion is to get the lunate neutral at the fusion site with the capitate. And so what I do is I decorticate everything. I flex the wrist, and sometimes I have to release that volar lip of the lunate, but I flex the wrist to get the capitate and lunate lined up. I place a 6-2 K-wire securing the capitate to the lunate, and then I can put the wrist wherever I want to put my screw in. And I've been really happy with that technique. And I always start there and then go to the other joint for fusion later. So I like that. I think it's probably easier putting a dorsal plate on in some respects for that very reason, but it hadn't been a huge impediment for me with that technique.
And for your ulnar-sided screw, separate incision, work through the same incision. If you're in a separate incision, how do you avoid the dorsocutaneous branch of the ulnar nerve as it's coming from volar to dorsal?
Yeah, I'd be interested to hear what you do. I do make a separate incision just distal to the ulnar styloid. I find the nerve or nerve branches and free them, and then go right for that tracheatrium to place the K-wire and then the screw. What about you?
I do the same, and it's funny because I did that, and that's how I remember learning it from Ryan Calfee when I was his fellow. And then I was teaching a fellow to do. I was like, "Oh, this is how Dr. Calfee does it too." And they're like, "Oh no, Dr. Calfee just does it through the dorsal incision." And I went to Ryan. I'm like, "What the hell?" And he's like, "Oh yeah, it changed." I was like,
Can't
"Great,
just change.
I guess." And he's like, "Yeah, it just made more sense to me." I was like, "Oh, that's good."
So let's say you have well, I just put it out there as a question. in a classic SLAC wrist, do you ever consider a complete wrist fusion? And do you ever consider wrist arthroplasty?
I think I have a higher threshold to consider wrist arthroplasty just because I'm not as well versed in it. And if I have anybody that's interested in it, I have a general sense of appropriate indications and, expected outcomes, I'll send them to Marty, since Marty Boyer, our partner, does that for our group. Although I admittedly want to learn more about it. And then, total wrist arthrodesis, I've done one for a SLAC wrist because the wrist honestly looked really beat up on the x-rays, and I had some concerns about the lunate, the radiolunate joint. So I ended up offering him a one and done surgery, and we did a wrist arthrodesis, and very happy.
I agree and disagree. I agree that there are certain patients that I think a wrist arthroplasty makes sense for. But for those patients, I have no interest in learning how to do a wrist arthroplasty, and I'm happy to send them to Dr. Boyer. But it is an older, lower demand population. There's another group that is very high demand and very bad arthritis, and a formal wrist fusion, a complete wrist fusion, makes sense. And so I do think those two operations come into play, although the vast majority of my SLAC wrist patients are treated successfully with either a PRC or a 4-bone fusion.
Fantastic. Thanks for playing Wheel of Hand Surgery. I will replace SLAC wrist with some other sportsy kind of topic, and we'll go from there.
All right. So listeners, if you like the wheel, let us know. If you think it's silly, let us know. Have a good one.
All right. You better like it.